So these are my disclosures. Let me just thank, of course, Giovanni and Max for your kind invitation of this amazing meeting. So this is a case of a 75-year-old male, high blood pressure, diabetes mellitus, dyslipidemia, and which is important to underline, end-stage renal disease with a patient on hemodialysis. And this is the chief complaint. It's an ulcer on the base of the fifth toe. And as you can see, no pulses below the knee. And what is also important to underline is that this patient have a prior failed attempt of BTK revascularization performed by our own team. So complementary tests show a non-raised white blood cell count. AVI was not compressible, and TCP2 was more or less 15 millimeters of mercury. We were about in 131 Wi-Fi classification. So all in all, we decided just to take him to the lab and to give a new chance. So we have a FEMPOP patent segment, P1, P2, and P3 was also patent. Three vessels were now but extremely calcified, but they occluded at the distal aspect of the leg, and at the level of the foot, none in vessels. Nothing really amazing. And if you have a close eye on the plain X-ray, you will see some calcification, which probably put this patient on a MAC4 score, which we have already mentioned has to do with a small arterial disease. So all in all, we have this patient with prior failed attempt, high SATMAT score. This is what we basically call a no-option patient. And I would like to ask the audience if you consider this the end of the story. So since I'm a sort of old-school guy, you're not going to need your cell phone. Just raise your hand. So how many of you could consider this the end of the story? None?
Nobody.
Really? So you don't need this talk? Okay. How many of you would consider this is the end of the story? None. One or two. So can you just back them up? Just ask them why they don't consider this is the end of the story. Just Mark, go for them. Ask them.
Yeah.
Pick one of them.
The end or not the end?
Any of them, because they haven't answered at all. So. You.
No, this is not the end of the story.
So what is your option then?
You are here to tell us what's the next option.
Excellent. Clever guy. Anyone else?
Come on, DVA at least is an
Okay,
option.
excellent. For those who consider that this is the end of the story, venous arterialization is...
I am the clown, this is story?
I'm
the clown?
You're
Okay.
the clown.
Okay.
So, venous arterialization has brought some new shots, green shots, of hope for these no-option patients. So, by the way, how many of you have already performed venous arterialization? One guy, the clever one. 3. Okay. Oh, more or less. 5. Have you performed? Yeah. Okay, 6 in the house. Okay, so as you know, we basically describe our own technique to connect the artery and the vein. This was published in 2018. We call that the VAS, the venous arterialization simplified technique. And if you like this presentation, at the end of the session, you can just check it out on your social media or on this. We have a nice webinar with a lot of questions and answers regarding the technique at Vascupedia. I strongly recommend you to visit Vascupedia. Okay, so how do we do that? So we get ultrasound-guided access, and then we puncture the vein. You see 2 veins next to the artery, and then we progress a V18 wire retrograde, and you see how nicely it just runs next to the calcified artery, and then we check that we are in the main trunk. We also gain arterial access, and then we progress the wire up to the non-crossable point, and at that stage, we progress the snare in the venous side. We initially perform a balloon angioplasty in the theia side to assure a good inflow. The snare on the venous side, the snare in the theia side. We put them parallel and aligned, and then using a 21 percutaneous needle, gauge needle, we puncture through both the snares, we pierce both the snares, we double check that the needle has crossed the snares, progress the small, smooth, all-footing wire, and then we retrieve the needle, close and retrieve the venous snare, and externalize the wire, and we also close and retrieve the arterial snare and externalize the wires. And through this through-and-through wire, we progress a balloon to assure the connection. Look at the waist, the crossover point. And look at this. This is the result. The main concern of most of the physicians is like, oh, it's going to be like a massive bleeding or leakage or whatever. Look, no bleeding, no leakage at all. So thereafter, we progress a catheter through the distal posterior tibial, and then we need to gain access into the lateral plantar and the venous plantar arch. So here we are, and we basically perform this with a curved catheter and a curved wire. And then we are progressing this. This is a mosquito clamp with a gauze that's trying to achieve some hemostasis of the venous access point. So as you can see, we progress the wire up to the level of the lateral plantar and the arch, and then we progress the catheter to check it out that we are in the good spot. And as you can see, this is the venous plantar arch, and then we progress our wire in the venous plantar arch trying to get the exit of the arch. You can either go for the medial marginal vein, this is superficial venous system, or the deep venous system, like in this case, and the wires in the anterior tibial vein. This is AP view, and thereafter we perform a balloon dilation in order to render the remaining valves at the level of the foot, the arch, or the distal posterior tibial vein. And then if you have any remaining stubborn valve stenosis, what we do is just to inflate a cutting balloon 4 millimeters, gently deflate and retrieve. It's a sort of valvulotomy maneuver for those of you who are involved in surgery. And this was described by the clever mind of Marta Lobato, who's my colleague. So this is the point when we have already reached the arch, but we need to drain this arch because otherwise you will have this roundabout effect of the flow getting backwards to the heart. And for this, what we do is trying to get access through the sixth perforator. The sixth perforator is at the level of the first toe. This is avulvulated, and then gaining access in the superficial dorsal system, the main vein of the first toe. So as you can see, this is following the theory by Roberto Ferraresi. He calls that the escape from the forest. So once we are there, we progress our wire trying to get access into the superficial dorsal vein. And as you can see, once we are there, we just check it out that we are in the proper place. And we perform an angioplasty to render the 2-3 valves at the level of this dorsal vein. You see the waist on the balloon. This is a 3.5 millimeters balloon. This is the lateral view. Look, nice breeze flow on the arterial side, crossover point, the venous side, and also at the level of the distal, posterior tibial, lateral plantar, and the arch itself, and a good drainage through this dorsal main vein. So the post-op course of this guy was slightly stormy, like it is usually. We have seen that these patients have what we call the storm post after DVA. So he needed painkillers, non-steroid anti-inflammatory drugs, but also usually they need an infusion of morphine. Another thing that we can see following these operations is swelling, which is slightly moderated when you perform a distal. And also you have this sort of, the aspect of the foot, this dusky foot cyanosis. And we deal with swelling with lack of liberation, and nowadays we encourage them just to early deambulation in order just to promote the Lajar's drainage. Regarding antiplatelet therapy, we put them on single antiplatelet therapy and also under anticoagulation. And at that stage, 2 days following the procedure, he had a nice posterior tibial pulse, ABI still non-compressible, and look, TCPO2 still 15 millimeters of mercury, because it takes quite a long time, several weeks, just to raise the TCPO2. So this is the aspect of the foot 10 days following the procedure, and you may probably think, well, this is even worse. Yeah, you're right. This is the effect of the Still syndrome on the remaining arterial network. So you have a necrosis where you have an ulcer. At some stage, 11 days following that, we realized that he had a weaker pulse. Is that mine? A weak pulse. And then we performed a duplex ultrasound to assess the flows, and we saw that he had 80 millimeters per minute. And we consider that something is going on, something is happening when the flow is below 100. So we decided to take him back to the OR, and what we saw is that we have an early recoil at the level of the arterial side. And to deal with that, we performed a balloon angioplasty. It didn't work, so we decided to scaffold the whole thing. This is a 4 millimeters self-expandable stent. And then what is nice to underline is the breeze flow, excellent outcome, but at the level of the vein, the venous side, everything was pretty fine, as you can see. So this is the foot. Okay, following this second procedure, things were pretty improved. Painkiller necessities were decreased, and he was discharged like 2 weeks following the index procedure. So at that stage, 1 month following the arterialization, we rescheduled the patient again to perform a flow focalization, and in order just to improve flow to the forefoot. And look at that. At that stage, we already had a rise on the TCPO2 up to 40 millimeters of mercury, and this is consistent with the outcomes of the ALPS study, where you can see this is the curve of the TCPO2. And what is really interesting to mention is that this rise on the TCPO2, which has this peak at the middle of the curve, it maintains this TCPO2 elevated regardless if you have a patent or an occluded graft. This is the idea of creating a new distribution system. So we needed to focalize this guy, so there are 2 main branches, as you can see at the level of the foot. We tend to coil the rear foot branches, but not the forefoot. So we use repositionable coils. These are detached from Boston. And as you can see, a good outcome. We have another main branch which is connecting to the arch, and this is usually connected to the lesser saphenous vein, and we use this branch just to do the bidirectional approach in order just to cross the valves or just for this sort of coiling. And then we also needed to coil the branches at the level of the leg, and the main thing there, there's something slightly cumbersome because as you can see, you have these 360 degrees, and you need to telescope or decrease the profile of your microcatheter. But sometimes what is easier is just to get access distally on the vein puncture, and you have a good access to the collateral to coil it. As you can see, we coil the big ones, also the small one, because they just ended up in a deep venous system. And then this is the outcome, the third collateral, which was coiled. So plain X-ray of the coils at the level of the foot, also at the level of the leg. So this is the clinical post-op course. 2 months following the procedure, we amputated the first toe because the patient had a wet gangrene. And as you can see, we left the head of the metatarsal bone. We learned that from Brian Lipow in Houston. It's a way just to preserve the medulla from the osteomyelitis. And as you can see, we had some infection, even a progression of the necrosis at the base of the 4th and the 3rd toe. But some spots of granulation already at 2 months, which become better 3 months. We schedule again to a debridement, and then at that stage we cut the head of the metatarsal. This is the 4th month. Nice, good evolution, and at 6 months, a really improved wound. Everything was granulated, and at the end of the day, 8 months, we were almost there, and as you can imagine, we were extremely thrilled. Okay, so the thing is like in our post-op course, 1 year later, we assessed the patient, we scanned him. He had a weak posterior tibial pulse. TCPO2 was still 65, and the ultrasound, the volume has dropped from 210 to 65, which entails that you have a failing DVA. So we were not sure what to do, to be honest. And we thought about let's contact a clever guy. But let me ask you, what would you do? On one hand, you have no wounds at all, a rise TCPO2 65, which could be enough just to maintain the foot. But on the other hand, you have a failing connection. So let me start by you. Daniel is one of the most experienced guys in the room concerning DVA. What would you do, Daniel?
Hi, August. Yeah, I would say typical case. Difficult question, though. No wounds, no rest pain, I guess. There is still some flow. I am also curious what's happening. So I would plan the patient for an angio and see what's happening. And if there's a, let's say, simple stenosis, I would treat it. Probably if there's a long reocclusion, I think I would leave it alone.
Okay, so the patient was asymptomatic. So let me ask the audience, how many of you will go for them, for just to retreat the patient? One. Oh, the fellow. Thank you, Theo. Anyone else? How many of you just leave it alone? One. Good. And how many of you still don't believe in ancestors? None of you. I think we need condylos just to stimulate people.
Yeah.
Okay, so we also were curious to see what was going on, and we scheduled him for a lab. And what we underlined that we have restenosis at the arterial aspect. This is a nice paper from John Rombach describing the patterns of restenosis in DVA. So we perform a drug-coating balloon for the in-stent stenosis, and also, as you can see, we take advantages to perform some coiling of one branch. We have early recall at the level of the tuboperineal trunk. We use an ultra-non-compliant balloon following Mark's instructions. And as you can see, the drainage was pretty good. This is the most amazing thing for me. 1 year following the procedure, we already have established the new distribution system. Okay, so this is the last follow-up, last couple of weeks ago. The patient was walking outdoor, no pain, no wounds at all. Posterior tibial pulse, TCPO2 still raised 65, and the flow was 215. So at that stage, we decided just to follow him up just clinically. So you have seen how to perform this using 2 snares, the VAS technique, but there are many different ways to perform the connection. You have a dedicated device. Daniel has extensive experience with the lymph flow device, but you can also connect the vessels using a re-entry device of the FEMPOP segment, like the ODBAC or the Pioneer. This is the technique described by Bruno Migliara. And you can also connect the vessels distally using the technique by Mariano, the curved catheter, CDO wire, or the technique described by Shihiuchi has it using a wire and a needle. And all of them have pros and cons. A must for proximal DVA is that you need a crossing device, covered stents. The must for a distal DVA is you need to assure a good inflow. And if you talk about hybrid, you need a good conduit. So due to the stents and the crossover stents, the crossover device, the cost when we're talking about proximal DVAs is increased compared with distals. And this 5 millimeters graph increases dramatically the flow, but also the main pitfall is that you also have an increased storm post-DVA symptoms. Patency, as you can see, it's a Achilles heel of all of these techniques. We're talking about like 3.4 months primary patency rates. The rates of redos, as you have seen, is really increased. And if it comes to redo complexity, for distal PTA, we basically perform distal DVA, we basically perform an angioplasty, whilst if you're talking about an occlusion of a graft or a bypass, you need a thrombectomy device or some lysis. So you may probably wonder what is the best way to do it. Proximally, distally, dedicated devices off the shelf. Well, so far, what we know, this is quite a scant experience, is that the outcomes of the techniques are pretty much similar so far. So it probably means that it has to do with everything but the whole, the way you measure connection. But we're still thinking, studying, and we have just the outcomes of the PROMISE trial. It's the largest trial available from the lymph flow side, has just been published. Really interesting. I strongly recommend you to read it. So for those of you that still think that these patients have no option, percutaneous DVA is still it's a good option, 60 to 70% limb salvage rate for patients that otherwise will undergo to a major amputation, which is a pretty acceptable outcome. So last question, and make me happy, please. Because when I arrive home, my kids will ask me, Was it good? I'll say that. They were slept. So, how many of you would think about percutaneous DVA next time? Yes? I'm going to give you another chance. Yes? Okay, just hold on. Let me get a pick. A no? Okay. Probably we're done. Thank you very much. If you've got any query, just get me there.
Thank you, August. Fantastic.